Morning. I'm going to go through the slides really quickly because I think I really can best serve your interests by answering a lot of questions about what we do in our pharmacy on a daily basis. But there are a few slides I want to concentrate on. So we get our prescriptions from the normal means of prescribers send us the prescriptions. Also, we have prescribers calling us about consultations. They want to prescribe a pain cream for their patients. And the common conditions that we see are just, knee and back. We get a lot of that. But we treat acute pain and chronic pain. And this is the question I think everybody's, how do we come up with the formulations? And in a nutshell, basically, it has to begin with a good conversation with the practitioner and the patient. We need to know what's the causes of pain. So when I'm talking to a practitioner, they want me to put together a formula or help them put together for a formula for a patient. We need to know what's causing the pain. And also, we need to really talk with the patient. We ask them, what's the pain like? What are the symptoms? And one of I think the most important questions we can have is to evaluate the history of the medications that have been tried and look at the positive outcomes and also the failures. And when we get all this information, we put it together, then along with the practitioner, we can start choosing the active ingredients that we want to use, the base we're going to put it in, and the application rate. And this is just a list of the APIs that we see. What I want you to take from this slide is that we do put some thought in on what strengths we're going to be using in a topical pain cream. A lot of times we refer to the consultants at PCCA or, the FDA monographs on how much a drug, for instance, on lidocaine, 300 milligrams is the maximum dose. So we, based on how we're going to be applying it, that's how we can come up with some calculations of what may be safe for that compounded pain cream. These are just some examples of the application rates that we use. A lot of times when a practitioner calls us and we have a new patient, our approach is, first of all, the pain creams are expensive. So if they're going to try treating 2 or 3 spots, that could be a very expensive thing. Most pain creams per gram are $1 per gram. So if you're going to treat several spots, 240 grams is a very expensive prescription. So the approach that we take with our practitioners is, let's try applying 1 gram to one single area, applying it 2 to 3 times a day. That way we have a 60-gram prescription that's far less expensive. And that gives them enough to evaluate the compound over a 20 to 30 days. When we compound these things, we put them in meter dose devices. And this is important because if you have a tube, there's no way of knowing how much a gram is. So in the pharmacy, when we get these compounds and they're finished compounding, we'll put them in a meter dose pumper. That way the patient can, dose it correctly. Another thing what I want to point out on this, these are non-child resistant, so we always counsel the patient on, safe storage of these products. These are some of the common formulations. If y'all have questions about it, y'all can ask me that. On the base selection, as far as me as a pharmacist, a lot of that is determined on where it's going to be applied, which is appropriate base, and also how many ingredients are in there. If the practitioner wants to use several ingredients and the concentrations get over 10 to 15%, then I'm going to have to select a transdermal base to compound that. This is just back to some of the comments that were made before. We have processes documented, so every compound that we make goes through the same process. That way we can ensure a consistent production of the compounds that we're dispensing. In our pharmacy, we have a lot of procedures set up to try to prevent errors. We have a clinical team. When a prescription comes in, it goes to a clinical team. It's staffed by pharmacists. We do look at the prescriptions. If we have questions, we call the prescriber. And then if we don't have answers for some of the formulations they want us to compound, we'll call PCCA. They have consultants on staff. So we do look at every prescription that we have coming in and, check it for, potential harm to the patient. Also in the lab, we have technicians that have been certified to compound these specific dosage forms. We test the technician. We also do random testing of the creams where we'll test the potency. We have barcoding and scale linking, and we perform QA. And also what's very important, that every compound going out of our lab is checked by a pharmacist. Patient counseling is really what I feel that we really have to do with these transdermal pain creams. The site of application is very important. The amount to apply, that's why we use the meter dose pumper, so we can give them a device that's easy to measure it. The amount of area we want them to cover. Also the duration they need to be using the topical pain creams. A lot of people think, well, it's used only on a PRN basis, and with the topical pain creams, it's more a duration of therapy. We talk to them about what their expectations are, how soon should they feel some relief from the pain cream, how long they should be using it. We go over any side effects, and we also go over the storage. Most of our pain creams are cash pay, and we've had some really good outcomes. If anybody has any questions about that, they can ask me. Thanks.